Hello, everyone, and welcome back to the RPE podcast, where we aim to bridge the gap between rehab and performance. I'm your host, Connor, and today I'm joined by Nathaniel. How are you, mate?
Good, mate. How are you?
I'm good, thank you. How's your day been?
Yeah, pretty hot up here. 35 degrees today. I thought it was starting to cool down. It's starting to heat up again this week, unfortunately.
I feel for you, man. It's just been windy here. Classic Tasmania.
What's the weather like down there, temperature-wise?
It's, I don't know, like mid-20s, which is actually pretty warm, believe it or not.
Yeah, okay.
Yeah.
Nice.
But unusually today, mate, we are not joined by Steve. We decided to sack him, thought he was just holding us back. We're the ones with all the knowledge in this trio of the RPE podcast research reviews. He's just a ball and chain. He's just holding us back. How do you reckon?
Definitely.
I reckon this is going to
It's
be
too hard to get him to commit to a time too. He's just such a busy man. He's got a busy life.
We just can't nail him down. It's just stressful. So I thought, stuff it. We'll just get you and me on here tonight, and we'll review.
Time to grow.
Oh yeah, maybe we need some other co-hosts or maybe some special guests just to beef up the lack of Steve.
Sounds good.
I'm sure he will disagree.
I'm trying not to swear at Steve right now. It's taking all of my self-control not to say an expletive in Steve's direction.
No, it is
or
a
flip
shame.
Him the bird.
It is a shame that we couldn't have him on. We would definitely value his opinion on this, because it's what we're covering today is going to be pretty interesting. But before we get into that, last week
schedules didn't work out this week.
Yeah, maybe next time. But we started a new thing last week, and I didn't get to say mine. So the question is
this
going
is for
to
last
be,
week, then, is it?
Yeah. No, I learned it this week. But the question is, what did you learn this week? So
did we just leave you hanging? Did you? Me and Steve had a big rant, and then you just sat there.
I think you guys told me in about 10 minutes how long it took you.
Yeah, I actually think that's why, because you were just like, okay, we really need to get into talking about the actual paper. So I think you're just like, I'm not going to talk about what I learned.
So I can't remember what I learned last time, but I remember what I've learned this week, and it's short and it's sweet.
Good.
So in the garden, we've got like corn growing at the moment, and I've planted all these flowers around the space where the corn grows, because I'm like, sweet.
Okay.
The bees will help pollinate all the vegetables and I'll get a good yield and blah, blah, blah. And then I was reading this thing about when to pick corn, and bees don't pollinate corn. Corn is wind pollinated.
Really?
Yeah. It blows about and somehow it gets pollinated by being blown on. I don't really get it, but.
So does that mean corn has like male and female, and pollination blows from the male plant to the female plant, or?
Maybe.
I don't know.
I think a lot
nature's complicated, mate.
Because when a bee pollinates, it needs to take pollen from a male or a female plant, or from a male plant to a female plant. And that's how that kind of happens, and it produces fruit and seeds and whatnot, which I didn't know about until like last year. So, yeah.
Oh, I sort of learned about that when I was growing up on the farm. Like I know one, for example, one fruit that's a good example is a pawpaw. So you got a male fruit and a female fruit, and the male plant doesn't produce fruit at all.
Yeah. I think avocados are the same, aren't they?
Not sure about avocados.
Because if you have one avocado tree, you need another avocado tree within like a kilometer. Otherwise, it won't grow avocados.
I'm not 100% sure about that, unless the avocado tree we have on the farm is just a female tree. But anyway.
And someone else has one from a little while.
Sidetracked. Yeah.
Anyway, I learned that corn is wind pollinated. What did you learn this week?
What did I learn this week? Yeah. Okay. I'm on the podcast at the moment. We're gonna have to cut that out. Apparently, Spencer peed in the bedroom.
Oops. Poor Spencer.
That's what I learned.
Liz or poor Spencer?
Poor Spencer, poor Liz.
How old Spencer? Surely
still in toilet training, apparently. Anyway, sorry. What did I learn this week? So, I've been listening to the Neuro podcast. I don't know if you've spent much time listening to that.
Yep.
I'm trying to remember the two guys that run it. But anyway, they had a guest on probably 12 months ago. I'm trying to sort of catch up on the Neuro podcast and have a bit of a listen to that. They had a guest on called Eti Ben Shabat, and she's like an expert in imaging in stroke patients. So the main reason I want to bring that up is because in the Musk space, we always talk about how MRI or CT, X-ray isn't indicative of diagnosis or presentation.
Mm.
And the podcast that she was talking about is actually, it's almost the opposite in some respects in neuro. And I was kind of like a little bit on the fence when she was talking about it, because I don't think you can look at someone who's had a stroke's brain scan and be like, okay, this person can't walk, or okay, this person's going to be able to walk, which is kind of what she was talking about. And it kind of just got my brain thinking about maybe looking at some brain imaging, and seeing if I can come up with what I think the person is capable of doing.
Mm.
But I think the brain's so complicated. I don't think you can just look at an image of a brain and be like, this person can walk, this person can't, because it's everyone's cortex is different. But it was interesting, just an interesting sort of, I don't know, thing that I want to sort of look into more, because I don't think I have a complete agreement with the fact that you can look at a brain scan and be like, this is the treatment I'm going to do for this client. It's going to work.
And these are the deficits that they're going to have.
A brain scan is going to always give you the right information. But it did sort of also make me think maybe I do need to look at brain scans a little bit more, become more familiar with looking at a brain scan, and just because sometimes things can be missed. So
yeah, okay.
Yeah.
Interesting. It kind of holds parallels like in the musculoskeletal setting to like osteoarthritis or rotator cuff tears or like loss of vertebral disc height. Like, yeah, we can see those things on a scan. But yeah, whether they are part of the person's deficits, picture, goals, life may or may not happen. Like there's so many incidental findings. Like, I don't know enough about the brain to say that there is or isn't incidental findings in the brain.
Yes, well, I would like you guys to have a look at that paper or research that she's doing and sort of pick your brains on it.
Yeah,
because I think she's sort of one side, like, brain imaging is like the gold standard, and obviously it's going to give you a lot of information because someone's had a stroke and roughly the part of the brain that's affected, but I don't think it's like completely the picture. I think because obviously neuroplasticity is always going to be a thing.
Interesting. I'm about to start reading a book called Live Wired, and that's about how like different parts of your brain can compensate for things that are lost or things that aren't functioning. So like, for instance, I heard about it, and this is why I wanted to read it, because it was talking about how blind people, more of their brain, like the different parts of their brain get better at like receiving tactile information or auditory information.
Or hearing. Yeah. Crazy.
And that can like take over parts of their like visual cortex. And like when they look at people who are blind and they get them to do stuff, parts of their visual cortex will light up when they're touching things or when they're hearing things. So I got interested in it. I don't know much about it yet, and I can't feedback to you whether it's a good book or not, but I'm about to start reading it. So yeah.
I think there's another one you might be interested in that Liz has in our library that I need to look at. It's like neuroplasticity or something along those lines.
Yeah.
Yeah.
Your camera's sliding around, mate.
Yes. It is. I've got a guest speaker on today.
With Spencer.
Spencer.
For those of you who are unfamiliar, Spencer is a dog. And
he needed to go downstairs.
He's wreaking havoc.
He's causing chaos at the moment. Anyway.
That would have been a good little segue into this paper, actually, because, yeah, MRIs and scans are quite often something that are taken when this injury occurs. And today we're going to be talking about ACLs. So we have a research paper that we are going to review. The last two we've done have been quite long and somewhat difficult to wrap your head around and took a little bit of reading. This one, nice and succinct, 1 page, front and back, done. So that's one of the reasons we picked it. Not because we're lazy. We just felt, we've had some heavy papers. We better get a short and sweet one on. So the name of the paper is ACL Surgery, When to Do It. It was an editorial in the Knee Surgery Sports Traumatology Arthroscopy Journal in 2020. It has 4 main authors. It's got Volker Masal, Teresa Diemir, Darren Dessar, and John Carlson. Excuse me. All right. So essentially, it's an editorial. So an editorial, for those of you who aren't familiar with editorials, is essentially like, it's not quite an opinion piece, but it's a review where the authors are using contemporary evidence to help them decide what their stance should be around a certain topic. So this one is pretty obvious: ACL surgery. When should we do it? Essentially, what these authors did was they went through some research, and we'll get into some of the research they picked. And the last sentence in the editorial was pretty damning. It was pretty certain. It was almost an absolutism. I'll just read it out. Non-operative treatment of ACL injuries can be discussed in less active patients. However, anything short of offering a young active athlete early anatomic ACL reconstruction would be a disservice to our patients. That's pretty heavy hitting. What did you think about that?
I think it's very hard to deal with absolutes when you're dealing with an ACL. I don't think you should 100% say whether it's surgical, non-surgical, without really assessing the client. But this is one of those things about doing an editorial with people who are surgeons. Like, they can have their own biases. I think if you and I wrote a paper on ACL recon versus non-recon, we'd be heavily biased towards non-recon. So somewhere in the middle is probably more appropriate.
Yeah, they presented it as pretty black and white. And the four authors, they are all orthopedic surgeons. So potentially there is some conflict of interest or some vested interest in some of the papers they picked. But they go through and they justify their decisions, or they try to justify their decisions. Essentially they open with defining 3 different types of people after an ACL injury. So they go, a coper. A coper is someone who can return to pre-injury levels without surgery and subjective instability. 2, an adapter, who reduces his or her level of activity to avoid subjective instability. So someone who just, if they injure themselves playing football, they just never go back to football, and they quote unquote adapt.
I can't play, like, I just can't play sport anymore. I'm not going to play sport anymore because I'm going to hurt myself.
It's not really adapting. It's just kind of
it's
reprioritizing. Yeah. And then 3, a non-coper, someone who can't return to pre-injury activity levels due to subjective instability and episodes of giving way. So they go through, they start off talking about screening for copers, and then they go through defining what a coper is. And
I'd also probably say a non-coper is someone who lacks confidence as well. Like, confidence is a big part of coping versus non-coping as well.
Potentially.
There's people who are very fearful around their knee or...
Yeah. So they reference the tests that you go through to become a coper. Mm-hmm. And these are something that I use just to see, okay, where we're at. Straight after injury, once the knee's kind of settled down, not as swollen, they feel like they can walk on it, they can weight bear comfortably, all that kind of stuff. So essentially they go through hop tests, quadriceps strength, the KOOS, so the knee outcome score, and just a general rating of, like, a global rating scale they give. So they just ask the person on a scale of 0 to 100.
How do they feel?
Yeah. How does your knee feel? And then they also say the other thing is 1 giving way episode. So they haven't had any other giving way episodes since the knee injury. So if you pass the hop tests, pass the quad strength, have no instability episodes since the injury, and your global rating scales above 80%, they would quote unquote call you a coper. So
would you be concerned about someone's knee having another give way result after an ACL tear if you were seeing someone in the clinic? Or would you not necessarily just say, oh, well, you're not appropriate because you've had another moment of collapse? Like, that's not really...
Yeah. It's a pretty arbitrary, absolute thing as well. Like, people are going to have different responses to a giving way episode as well. Right.
You don't have an ACL. So there is a chance you're probably going to have another give way episode at some point if we're challenging it.
Yeah, potentially. And then again, like, your ACL isn't the only thing that's stopping anterior translation and valgus at the knee. Like, there's other things that are doing that as well. So I think, if the person has an instability episode and it really flares up, or they just can't get back to settling the knee down or whatever, then sure, whatever, we won't call you a coper. But what if they do settle it down and then they get everything back and they can do everything again? Like they don't talk about that option. They just give you a one and done type approach. Like, I don't know how, obviously what they're worried about there is the risk of damaging the meniscus or accelerating osteoarthritis and things like that. But again, that's not really substantiated in what we see in the literature. They go on to say
Right.
that.
That's what I was just about to ask you. Isn't there a lot of research saying that that's a bit of an urban myth around ACL? Oh, if you don't have an ACL recon, you're going to end up with chronic OA in your knee at 30, and your meniscus is going to be ripped to shreds. Like that's not really a thing anymore, is it?
Yeah, well, it's potentially, there's more nuance around it. It's not as black and white as that.
Yeah.
Like,
yeah. But that tends to be the picture that's being sold to a lot of.
Exactly. And if you're selling that to someone, like, oh, I had this happen the other day with a 16-year-old girl come in. She's been doing really well. She had to, this is another thing, the health system, she had to wait 4 months to get in to see the surgeon post her ACL injury. So we started rehab immediately and got her through, and she's gone really well, back to running, et cetera, et cetera. And then the surgeon so she had an MRI about a week after it happened. The surgeon took another one 4 months after it happened to check for any like meniscus injuries or things like that. She was all clear, all fine, but her ACL had started to grow back. So
that's awesome, because I've never seen that personally. I've read that in the literature, but I've never seen it actually in a case. That's pretty cool.
So what did this surgeon do? He said, okay, so we're definitely going to need to repair the rest of that ACL. Otherwise, you're going to end up with knee OA by the age of 30, and then you'll need a knee replacement at age 40. And this 16-year-old girl, one, burst into tears because she was so scared of it. And then two, came back with an absolute bucket load of questions and a little bit of lost faith in me.
And fears.
Yeah, so many fears. So anyway, we managed to talk her down. That's beside the point. But if you're priming people with that as the consequence, and it's potentially not well supported, then of course people are going to want to choose the surgery.
So just rewind for 2 seconds. You said that, what was the main reason that she hadn't got immediate follow-up with the surgeon? Like you said, there was an issue, like
just the wait list on the public system.
The wait list, right?
Yep.
So, but she's in the public system for surgery, but seeing you privately as a physio.
Correct. She doesn't have like hospital cover or anything like that. So,
okay. All right.
She has.
So they still wanted you to sort of work with her until she essentially got off the wait list for surgery.
Correct. And that was a decision that we made with her at the start. I was like, okay, you can go see the surgeon. What do you want to do? She said, I might try some rehab first. So we did. I was like, cool. They've given you this date for your surgeon appointment. We'll just rehab up until then, and we'll still get an opinion from him and just see what happens.
Mum and dad involved at all, or just?
Yeah. Mum and dad were pretty happy with what I was talking about, avoiding surgery. And so
how'd they feel about what the surgeon said?
Yeah, I got some pretty heated questions, which was fine. But it's just, the things I took her through and the things I spoke to her about, we managed to kind of get her back on track, and she's going well. We're 6 months post now, and she's returned to soccer training. She hasn't had the recon yet. She wants to.
She is still going.
She wants to avoid it. She wants to avoid it. So at the moment, she's a quote unquote coper. This paper goes on to say the rate of true copers in the literature is low. And I reckon the reason for that is because up until recently, we just do surgery straight away.
Yeah, there's no evidence of it, is it? Because we just operate like 2 weeks after someone's had an ACL, bang. So you don't know whether they're a coper or a non-coper because they're just getting operated on.
And there is a bit of evidence around this. They just, for whatever reason, give them the benefit of the doubt, didn't include it in this research article or editorial, we'll call it that. So the paper that they did reference, they said at 10-year follow-up, 93% of these previously designated quote-unquote copers underwent ACL reconstruction. So they didn't say why. They didn't say, essentially, did they have another injury? Did they have concomitant injury? So I read into that paper a little bit more. And from that paper, 63 out of 88% of copers got back to sport and didn't sustain any extra meniscal or chondral injuries. So I'm not sure where they got that 93% figure from, but
that was the paper they quoted.
Yeah. So then based on that paper, this is a huge statement based off that paper. Therefore, in young active patients wishing to return to jumping, cutting, or pivoting, ACL reconstruction remains preferred treatment. So yeah, they've essentially already covered off that there's copers and non-copers. However, they think that copers eventually end up being non-copers, or they end up getting the reco. There's so many things that could cause you to get a reco. Like if you've got surgeons telling you, oh, eventually you'll need that reconstructed, or maybe you do have a true instability event, or maybe you can't quite get back to the level you want because the rehab wasn't good enough, or whatever. There's so many different reasons, and they don't report on that. And this group just take it as, yep, everyone should still just have surgery. So that was one thing that I kind of wanted to question. And this was kind of fed to us at uni as well. So whenever anyone had an ACL injury, they were immediate referral to a surgeon, an immediate referral, or immediately just got it fixed. There was no real, we didn't really get taught about conservative or non-surgical management. It was just, here's your prehab for your surgery. You're going to have the surgery.
It's true. The same with shoulder injuries as well. Do a prehab and then go see a surgeon. I mean, do you remember when I injured my ankle? I had a lateral ankle injury. And the first thing I did was go to hospital, obviously, have an x-ray, and then went straight to a surgeon.
So you fed into that system straight away. You're not even given a chance to try rehab.
Yeah, that's right.
So yeah. I just would ask where that assumption that ACLs can't heal came from. Did we got taught at uni as well that things that are intracapsular can't heal? So that's just kind of being grandfathered into our thinking without really ever questioning that assumption.
In their defense too, because we're getting taught this stuff, they are obviously getting taught that as well. So I guess the question I have is, how do you bridge this issue? Like, because I believe unless we change something, like, they're going to continue to feed this information to people. Do you think they're going to be open to a discussion with physios about the fact that, well, why are you operating? Why are you always suggesting recon? Like, are they going to be open to that idea, or are they going to be a lot of pushback because it means less money?
So yeah, exactly. There's a few things here. There's the appeal to tradition. It's something we've always done. It's worked. We know that it does work. Like if someone has the reco and they rehab well, they can get back. There's the appeal to authority in the hierarchy of the healthcare system. The surgeon is at the top, and what they says goes, regardless of what a physio or a EP or someone like that might say to them. And then there's the appeal to consequence as well. So like if you don't get this done, you will have knee OA and you will have concomitant injuries of the meniscus and things like that. So people are like, I can 100% understand why people are still doing it without the rehab side of it. But I don't know how substantiated those claims are if we can really base it on empirical evidence. From what I'm hearing with like the Canon trial and the cross bracing trial that are about to get released again, ACLs can heal. People do get back to sport with conservative management. So it only takes one person to have an ACL heal to prove that it can happen. So yeah, I just don't know where that assumption came from.
I just thought of a pretty cool example of that. When I used to work in private practice and dabbled in Musk before I became a neurophysio.
Good.
I had a bloke come in with some sort of lower back injury from lifting, footy player. And we the back started to come good. And he's like, oh, while I'm here, do you mind just having a bit of a look at my knee? Like, it's been feeling a bit weird lately. Sort of got through the assessment, and I'm like, and I'm not that confident in my Musk, like in my knee testing. Like I've always said that I've really always struggled. And he's a big dude, big boy. So like I wasn't that confident in my testing, but I'm like, I have like I'm pretty confident. Like I'm not confident, but I am confident that you actually have an ACL tear in your knee. And he's like, huh? And I'm like, look, let's go get an MRI. And he had an ACL tear, like a 2-year-old ACL tear that he didn't know about.
And he'd been playing footy.
I was working with. He'd been playing footy. And he'd seen a physio at that clinic previously for the knee injury like 2 years ago. And had been diagnosed, really good physio too. Like I really like the physio. I'm not having a go at physio. But I think he'd also had a pretty complex history with his knee, like PCL as well, meniscus
Mm,
on one side, like, and he was just like a little bit shocked. He's like, shit, that's why my knee hasn't been feeling that good.
mhm.
And managed to sell conservative to him. And now I just sent him a message. Actually, he's about 2 years post conservative, and he's starting for the team. Knee feels great, and I'm like, fantastic.
Yeah.
So it's definitely possible. And he's a big boy. Like he had to
Mm.
get crazy strong because of how much weight he's got. You know, changing direction when you're 130 kegs. This is a fair bit of
Big
force going
dude.
through that knee. But he said it feels great. So
Yeah.
that's a
Awesome.
little win when I was back in the Musk world.
So yeah, there's all these examples of like case studies where it happens once off. Therefore, it can happen. Maybe we just haven't given it the chance to happen in more people. And I think that's what they're saying about the lack of knowing who true copers are and aren't. And
And I guess what I just said then is technically we got to be careful. It's technically anecdotal evidence, isn't it?
yeah, it's
It's
a
not.
it's a case study though, and it's
Yeah.
anecdotal evidence. It does have some weighting, but I think we should try and get some more actual research around this to like before we have such black and white conclusions like this paper did. Um, so yeah, I think that was important to talk about. The other thing they kind of did throughout the paper was they kind of contradicted themselves a little bit in some of the evidence they picked to kind of highlight their points. So there was one here that said of the okay. In fact, a recent randomized control trial of 121 active adults, median Tegna 9. We'll go into the Tegna scale in a little bit. 59 patients were allocated to rehab with optional delayed ACL reco treatment arm. Of the initial non-operatively treated patients, 40% after 2 years and 51% after 5 years opted for delayed reconstructive procedure. The consequences, which entailed significantly more meniscal injuries, patients with 6 menisci versus 19 patients with 29 menisci injuries. A dismal 36% to return to injury level of activity at 2 years, and a mean Tegna as low as 5. So they've started off, let's go into this Tegna scale. So the Tegna scale is weird, but essentially it goes from 0 to 10. 10 is like national elite soccer, rugby, netball, basketball player. Level 9 is competitive lower division, like soccer, football, rugby, or ice hockey, wrestling. Level 8 is competitive racquetball, squash, badminton. Level 7 is just competitive sports as tennis, running, motor cars. 7 just recreation, 6 recreational level, and then 5's just like heavy work. So they're saying these people went from like Div 1 soccer players and whatever else to being only able to do heavy work in that one group. Then again, they've used that to highlight the difference between people who had the ACLR and the people who didn't have the ACLR. So people who had the RECO, people who didn't have the RECO. And then later on down the track, they go on to say patients with a high recreational activity level of 6 were compared for range of motion, blah, 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 and they had a better outcome. It's like, well, 6 isn't a good outcome. If you've said 5 is dismal and now you're saying 6 is good, I think you might be confusing the Tegna scale, or you're just using
Yeah.
the wrong examples to highlight your
I don't think the Tegna scale sounds like a good way of like
no,
determining whether someone's had a good outcome either.
no.
It's
Like
such a what's the word for that? It's core qualitative. It's like a qualitative scale. Is that what you're saying? Or quantitative?
it's
Qualitative.
uh it's kind of
It's a
quantitative because
weird.
it's quantitative, but it's a strange scale to use. I don't think we get into it there, but they
Well, it's
kind of
so broad. Yeah.
they've kind of contradicted themselves there, saying people who don't have it only get back to a 5, and people who do have it get back to a 6. It's like, okay, so they can lift heavy stuff and jog.
Yeah.
It's like,
And I mean, is that even a significant? Is there a significant difference between the two? They don't
yeah.
even really discuss that.
And that was a
As far
recent,
as being statistically
yeah,
significant, is what I meant.
that was a recent study. That was done in 2008, the one that they quoted there. So that's 14 years ago. This paper was in 2020 though. So at that point, it was only 12 years ago. But there's been plenty of research come out since
But
then.
there's been research in the ACL world between 2008 and 2020 that they haven't really even addressed or talked about.
Most of their research is from like 2000, 1998, 1999, everything pre-2010. There's a couple of 2014s, 2015s, but nothing super recent. Which, is like, I don't know how much that weighs on their conclusions as well. So they didn't really go into how they searched for the things they searched for. They didn't do a literature review, or they didn't go into methodology of where the literature review came from, which kind of makes me think they might have just Texas sharpshooter old cherry picked it. So
correct. That's kind of the vibe I'm getting. If we're cherry picking articles that are older in the ACL space and ones that sort of confirm their beliefs and biases, and we're not allowed to attack.
No. You attack the claims, not the people. So,
right.
Yeah, I think that hopefully our rehab and our return to play criteria has improved a lot, and there's been more studies into that over the last 5-10 years as well. So I hope the research that they are referencing here, probably our rehab wasn't very good either. So like, I don't want to say it all.
That's another thing I was going to talk to you about, is like, it doesn't really discuss what rehab process those people underwent, and they probably all had different rehab processes they followed. Like some of them mightn't even had like intensive rehab, so it's not really surprising it failed. You know what I mean? Like there's a lot of holes in it.
The one I read where there's 72% of the copers got back to sport in a year or whatever it said. I read their research, their rehab protocol, and it was like E-stim, inner range quads, mini squats. There was nothing about like turn to sport testing. There was nothing about like jumping, heavy strength work. There was like nothing to do with like what we would call strength and conditioning, aerobic work even. It was just like E-stim, inner range quads, mini squats. So they're basing their whole argument off that being rehab as well. And if I
Which really isn't, is it?
Fair enough. Like no one is going to do well with that rehab.
No,
so
correct.
Everyone in that environment should get an ACLR.
Yeah, correct. Yeah. And your copers aren't really going to cope because they're not getting enough load to begin with.
No, so
they're set up to fail. Your copers are going to fail if they're not getting worked to the point that they return to sport, which we know does happen. It does happen all the time. And that's the one thing I think that we kind of need to encourage in new physios is breaking down that hierarchy that we were talking about. Like, I understand surgeons are but we don't need to be scared to push back and disagree with them. Like, I think all the time we're like, oh, this is the surgeon's protocol and we're not going to do anything that surgeon says we can't do. It's like, don't be afraid to question protocols. Yeah. I'm not saying go completely against the protocol, but don't be afraid to call them up. Discuss the protocol with them. Like, okay, why are we doing that? Why aren't we allowed to do that? Well, I think we should be able to do that at this point. And I mean, the surgeon might get really shitty, but some surgeons may appreciate that. Some might just tell you to go get stuffed.
And that's where that like logical fallacy of appeal to authority comes in. And that's where I think patients get sent and physios get sent. And it's hard to bash back against. Like, it's something that's hard to like go through. So yeah, while we're on the topic of logical fallacies, that appeal to consequence, if you don't do this, then this will happen. They go on to say in this that osteoarthritis and arthrofibrosis are some of the main concerns of not having an early reconstruction. So they go on, they say how they're the potential risks of not having early surgery. Then they say this: in fact, osteoarthritis is seen after both operative and non-operative treatment and might be related to the increase of inflammatory chronodegenerative cytokines in the synovial fluid in ACL injured knees. If that was the case and it's an inflammatory reaction, another trauma to the knee via surgery could potentially increase that, could it not?
Make it worse, potentially.
So
hypothetically,
they don't mention that. And then they go on to say arthrofibrosis following ACL reconstruction is a major complication. And then 2 paragraphs later, a clear correlation between the timing of ACL reconstruction and the incidence of arthrofibrosis remains elusive. So they don't have any data on it, yet they've called it a major complication.
Risk.
Exactly. And the fact that delaying it, it's like delaying a surgery itself is risky.
And they still don't address non-operative as an option. They're like, well, this basically, all this means is that there's a chance you're going to get that. So you better have it quick. Have it early.
Correct. Yeah. And potentially you get it earlier if there's just a huge cascade of inflammatory things going on.
Yeah.
And then the same guys under the same thing. A delay of surgery is not without consequence, with repeat episodes of giving way associated with an increased risk of subsequent injuries to meniscus and articular cartilage. Again, the study that they referenced at the start said that 72% of copers got back to sport and didn't sustain chondral or meniscal injuries. So the cognitive dissonance here, like reading these things, is just
Pretty scary.
Yeah, I just don't know how.
But it is an editorial. This is the whole thing, right? Is that it's not peer reviewed. So really, you can just go on there and say
peer
whatever you want.
reviewed,
Is
but
it?
yeah, it should be. It should be. It's still got to get into the
But isn't it an
journal.
editorial? Yeah, but isn't it just meant to essentially be an opinion piece? So this
Correct.
is what they believe. This is what their opinion is. It's not actually like a
But
study.
It's also in the Journal of Knee Surgery, Sports Traumatology, and Arthroscopy. So the people who are reviewing it are going to be surgeons.
Yeah.
So if they're just like, oh yeah, this seems fair, we'll throw it through, it's getting in. Yeah. So that appeal to consequence, I just don't understand how in the last sentence you can say anything short of offering a young active athlete early anatomic ACL reconstruction would be a disservice. How can you say that based on the evidence that you've presented in the page before?
Because I mean, they haven't even talked about young athletes or 16-year-olds or whatever you want to talk about. It's very strange.
The last thing I think we talk about is their definition of early. So getting early reconstruction. So early was defined within 8 days after trauma and delayed after 6 to 10 weeks. Question 1, what happens between 8 days and 6 weeks? That's the first thing. I don't really know what's going on there. Also, especially in Tassie, no one's getting to see a surgeon within 8 days, even if like you're an elite athlete. Like it's going to be tricky to get in. Like everyone's so booked in.
Even with private surgeries.
We're understaffed.
So private health. Really?
Yeah. Everyone's going to have a quote unquote delayed surgery. Like it'd be super rare to get someone in, unless you're like a jack jumper or like a Tassie Devil or a Hobart Hurricane or something.
I don't.
They
ever fly people to Brisbane to get surgery? Like, do people ever go to Brisbane surgeons?
I reckon. They probably
want to get done real quick.
They probably go to Melbourne, to be honest.
Oh, Sydney, yeah, fair enough. It's a bit closer, isn't it?
So they go on to say that the early reconstruction group had less loss of muscle. Patient-reported outcomes were similar. Knee range of motion was similar, but the economic burden was more. So it's cheaper for the economy and for everyone if we just do ACL reconstructions.
That's the other thing that I wanted to talk about when we're talking about the less muscle loss.
Yeah. Hypertrophy. Less hypertrophy. Yeah.
In the early rehab. Early surgery.
Yes.
So that makes me think, just based on that statement, that these people aren't doing prehab.
No.
They're just literally sitting around waiting for surgery.
Yeah.
Because otherwise they wouldn't have muscle loss.
Yeah. So
or it would be comparative, if that makes sense.
Yeah. It wasn't much. Like the paper they referenced, it was not much. So yeah. I just don't think what they've used to substantiate their claims really adds up. But yeah, I think in summary, this paper is full of bias, appeals to tradition, appeals to consequence, appeals to what did I just call it? Appeals to authority, so the hierarchy of the system.
Hierarchy.
Yep. And doesn't really do a good job of representing their point. What did you think?
Well, I agree with that. But we also talk about it's not really a fair representation of what ACL patients go through. And there's a lot of gray, like the very pinpoint on, okay, this client needs to have surgery. If you don't have surgery, these things are going to happen, which is what you were talking about.
Yeah.
But I think it's just important that we, as physios, try and cut through that and educate patients and let them know that it's not always necessary to have surgery and give them the option. Because at the moment, if you're seeing a surgeon and you're not following up with a physio, really given that option unless your surgeon is really, really pro physio, and it's quite rare.
Yep. Yep. I'd agree. And just with some of the papers that are coming out, like this is an emerging field. It's something that we're starting to research into, like that Canoon trial. They didn't mention that anywhere in here. And from what I'm hearing, with the cross bracing protocol, that's a new bracing protocol came out.
Okay, cool. I haven't heard about that.
Essentially, I think what they do is they have your knee like braced in 90 degrees of flexion for 4 weeks, and then they let you have an extra 10 degrees of extension over the next 6 or so weeks. And I don't know if the paper is released yet, but I was listening to another podcast with one of the authors, Steph Filbay, and she was saying something like they had a 92% heal rate.
So it's a little bit similar to conservative management of an Achilles tendon.
Correct.
Where you start them in like plantar flexion and then slowly work your way through range.
Yep.
Cool. That is really cool. It's
Yeah.
something that's never really been done either. Like,
nope.
Like we said, generally it's just like, okay, you're for surgery. That's really cool.
So yeah, I think that's exciting, and it's going to be emerging in the next couple of years, I think. So watch this space. But yeah, do you have any other thoughts about this paper? I think we probably
bashed it.
Well, we probably bashed it a bit.
I think the thing is that I just find interesting is that this sort of thing can be published, and I'm not shitting on it. I'm not going to shit on it anymore. But the fact that it's like 2 pages long to me is a little bit insane. Like they don't really talk about data.
No.
Like when you sent it through, I was just like, how is this? How is this a paper? And they've literally just referenced like 3 papers that agree with them and gone, therefore. Well, it's just blew my brain a little bit.
They referenced 34 papers, so they did look at it looks like what we tried to do at uni though, where you type something in and then you go to your end note and you see, okay, where does this sentence pop up in another? And then
that's literally what it looks like. Yeah, 100%.
We'll just reference that.
We'll reference it. Yeah, it's like oh, let's just put 1,000 papers into our bibliography and see if they notice.
I appreciate the concisity of the paper, like 1 page front and back with like 2 lines on the next page. So that's unreal. But obviously you can't get all the nuance across in 2 pages. So potentially if they picked like a 6 or 7 page editorial, maybe they would have gone through all that nuance and maybe they would have had different reasons. But based on what
I think the other thing that is concerning, sorry to interrupt you, is that there's no mention of non-operative. Like that does actually, the more I think about that actually really just concerns me.
Well,
it was done in 2020.
Yeah, they mention it, but they just bash it. And when they're talking about non-operative, they're using words like dismal, and like they're just using loaded words to like try and represent their case a little bit more. So
this is what I'm saying, and we can talk about this forever, but I don't know where we go as far as it's about breaking down that barrier and trying to get in with patients before surgeons see them in some respects. I mean, obviously people have surgeons that they get along really well with and have a good rapport with and that are pro physio. But I think this editorial kind of shows one of the major issues and barriers that we have as clinicians when managing ACL patients. And you told your story. You know, that happens all the time. And it's not just ACLs. You're working with a patient 3 or 4 weeks and then they'll go see the surgeon and they'll come back with just all of these like fears and misnomers about physio and non-surgery. And it just drives me nuts. And you undo about 6 weeks of education in one appointment, 1 10-minute appointment.
And the nocebo is real.
Yes.
The nocebo is real. Yeah. What is it? What's that law? It's Brandolini's law. I think that's it. It takes inexorable amount of good information to undo 1 bit of misinformation. I think he uses the word bullshit. Or it takes, to undo a lot of bullshit, it takes like 10 times the amount of effort to dispel it. So I feel like without bashing surgeons and things like that, sometimes that's what does happen in those interactions with clients who come to see them. And yeah, it's like you mentioned that they get a 10-minute appointment. They don't really get a chance to sit down and actually ask the person what their goals are, because potentially, maybe they don't want to go back to sport immediately, or it's the off season and they want to try some rehab, or they don't seem to take into account any of the client's wants, needs, desires, goals, experiences, that kind of stuff. And they just, under that paternalistic model, go, you need surgery, or this will happen, or this will happen, or this will happen. And they don't tell them about the risks of surgery, and they just go for it. And that happens all the time. So
And if it fails, it's the physio's fault.
correct. Yeah. Oh, you didn't do your rehab well enough, or yeah, it's in an unfair space at the moment, but I would love to see, in like 5 years where it gets to. Because
It is getting better.
I think
It is
so.
improving. I think physios are doing a really good job. But like I said, I don't know. I feel like a discussion needs to be had. Like, I don't know how you even go about starting that, breaking down that wall.
The cross bracing method. So his name's Tom Cross, and he's an orthopedic surgeon.
That's
and
rather hilarious.
His dad, I can't remember his dad's name, but he was the one who had the theory, and then Tom, I think, is his name. It's Cross. It's not a cross brace. Their last name's Cross, and then they have the protocol. They're orthopedic surgeons trying something slightly differently. And it's kind of a
so
common
is the
sense
theory
approach.
there that they're essentially putting the knee in the position where the ACL is at its shortest point,
So
trying to get it to heal back together?
if you tore it, the ends would be the closest together, so it would
That's
be
right. At
trying
90.
to trying to get
them, that
close
makes
back
sense.
together. So
And then over time, they sort of increase the range of the bracing.
Mhm.
Is that right?
Yep.
Yeah, that's really cool. I'll have to look into that. You'll have to send that to me.
I don't know if it's out. Like there's
Okay, right. If you type in very early on,
if you type in cross bracing protocol, it pops up, but I couldn't see any studies attached to it. I think they're about to release it. But watch this space. It's going to be interesting. I just can't believe that no one's even tried that though.
it is pretty wild.
Like I think ACL recos have been around since like the early 1900s. It's
always been one of those, like you said, I can't remember the word you use for it, but it's like, this is how we've always done it.
Yeah. Tradition.
And no one's ever really questioned it. Yeah, tradition.
Yeah. So I don't know. I think we did. Hopefully we didn't offend surgeons or shit on anyone too hard. But this paper probably didn't do a good job of what it was trying to do. Whether it should have been trying to do that, don't know. Like, I just think that it's too aggressive a statement at the end of it based on the evidence that they've shown to us to make that call, the call that they have, that everyone should have it.
Particularly when it's being posted in a knee surgery journal. Like,
correct.
I guess it's always going to be pro surgery, but I'd like to think that they would at least discuss the potential of not needing to operate. But anyway, that's one of those things we could talk about for a long time. It's one of my massive pet peeves.
We're probably a little bit optimistic, mate.
Yeah, probably. And this is the same thing. It's like anything. There's good physios, there's bad physios, there's mediocre physios, there's good surgeons, there's bad surgeons. Not every surgeon is just like, bam, can operate.
There's good papers, there's bad papers.
Correct.
Mm-hmm.
Correct.
So
where we live in.
Yeah. Do you have any other thoughts on that to close it out?
No thoughts. A bit different doing an editorial. Like I said, reading it made it a bit harder to talk about. Not as much information to get through though, which is also positive. So I didn't have to go through all the data and try and get my head around that. So,
how do you think we went without Steve for the first time?
Steve, he provides a really different perspective. I think
he's just smarter than you and I, and he probably just carries us real hard.
I think he is very, very smart, and he's sort of on the front of like challenging a lot of physio treatments, like in the space that we work in. He probably would have tore that to shreds, but hopefully we did him proud. He would have had some good references to talk about as far as like what current evidence is. That's one thing that Steve is really good at. Is a bloody encyclopedia when it comes to like current evidence. Like I know you referenced the Conan trial.
Canaan, yeah.
Canaan. So
I
know him and Jeff. Canaan. Yeah, him and Jeff talked about that on Jeff's podcast, the Be Strong Physio.
Yep.
Is it Be Strong? Be Strong Physio podcast for anyone who is listening to this. The few people that are, give that a listen.
All 4 people.
Jeff, all 4 people. Jeff
Yeah.
is doing a really, really good job. He's getting pretty different guests on there that are challenging the current evidence in the physio space. So that's good.
And he's got some good resources around ACL non-operative treatment as well.
Yes. So if you're having trouble treating ACLs or not sure where to go next,
shout out Jeff Ford. Be Strong Physio. Anyway,
Mick Hughes is another one that's really good.
Yeah,
obviously.
Mick Hughes.
I think everyone knows Mick Hughes, but Steve and Jeff touched on that very briefly in their podcast about, I don't know, you probably listened to it as well, but it's so true. And I know I fell into that trap treating ACLs as a new grad. It's like, oh, what's the Mick Hughes protocol? All right, let's go through this. We're going to follow this step by step. Yeah, the Melbourne ACL. And it's so true. And I think so many physios as new grads, like if you don't have a good mentor in that space, would just be like, cool, I'm just following this protocol and we'll see what happens.
And to be honest, that protocol would be better to follow than most of the rehab that was getting done.
Oh, absolutely.
10 years ago.
Yeah. Yes, definitely. Yeah. Like you're probably not going to, I think Steve talked about it on that podcast. Like you're not going to hit every single client, but you're probably going to have pretty successful rehab with 90% of your clients. Probably. But it's about those 10% where you like can't quite work out why they're not getting better. But that you have to be able to think outside of that protocol. But anyway, that's another one.
Well, we got through a couple of good shout outs there, Mick Hughes and Jeff Ford. We might see if we can get one of them on in the future to help us discuss some more ACL things. But I think that probably wraps up this paper and wraps up this episode. Thank you, everyone, for listening. That has been hopefully not an RP10, not as long, not as heavy. But thank you for listening, and we'll see you next time.
Thanks for having me, Parky. I'll see you next time.
Sounds good.